The topic of discussion that we'll be discussing right now is we'll be talking about nephritic syndrome, and under this nephritic syndrome, the thing that we'll be focusing about acute proliferative, right? And under this acute proliferative, we'll be talking about what? We'll be talking about Post-Streptococcus Glomerulonephritis, that's PSGN. So the thing that we'll go through is we'll go through the definition of what Robbins, and then we'll look toward this note. We'll just go through the diagrams, the figures that are mentioned in Robbins, and then we'll go toward the content of first aid and what, and then if we get time we'll just we'll do the sudden recap from our this Robbins, the contents within our Robbins. So without delay, let's move into our discussion. Now talking about our discussion, now beginning our discussion, the first thing that we need to know is this nephritic syndrome. This our nephritic syndrome, as you can see I right here, it is associated with what? It is associated with inflammation. So what is nephritic syndrome? It is the condition in which there is inflammation in our glomeruli, right? Okay, we can go right here. The glomerular disease presenting with nephritic syndrome, right? Nephritic syndrome are characterized by inflammation in glomeruli, right? Okay, that there is, so what I'm saying is, what I'm focusing is simply what is nephritic syndrome. It is what? Inflammation in glomeruli. Okay, now the main characteristics that that we need to study about this nephritic syndrome is, right, the thing that we need to the main cardinal feature that are associated with our this nephritic syndrome are what? These are, the first one is our what? Oliguria. What is the first one? The first one is our oliguria. Now this, what is this oliguria? Oliguria is the condition in which there will be decrease in urine outlet, right? And that's what? That the urine will be less than 400 ml per day. And another feature is our proteinuria. Now proteinuria, since we know that the protein are not filtered by glomeruli, but in the condition of nephritic syndrome, what will happen? That because of inflammation in glomeruli, there will be what? Filtration of protein, and we will find proteinuria. We will find protein in our urine, and that's especially we will find albumin. Okay, similarly another thing that we need to know is our glomeruli does not pass RBC. In normal condition, the RBC are not passed through our what? Glomeruli or filtered by glomeruli, but during its inflammation, what will happen? There will be passage of RBC, and those RBC will be ruptured because of what? Because of the inflammation in glomeruli. Well, they are passing through the inflamed area, so there our urine, there will be presence of what? There will be presence of blood, hematuria. Okay, now another thing that we need to know is, as there will be what? There will be inflammation in what? Inflammation in glomeruli. What will happen? There will be decrease in what? There will be decrease in our glomerular filtration rate. As there will be a decrease in glomerular filtration rate, what will happen? There will be activation of what? Renin system. As there will be activation of renin system, there will be what? There will be aldosterone that will be retaining sodium and water, and that will eventually cause what? Hypertension. So another thing is our hypertension. Okay, now along with it, I would like to mention one condition, and that is what? That is our, okay, there is one important condition that we need to know that is not mentioned right here, is our what? Hematuria. Okay, right here, the thing that we have discussed so far are mentioned right here. So hematuria, yes, proteinuria, and what we have is we have agitemia. Now what is this agitemia? This agitemia is increase in blood nitrogen level or serum creatinine level, and another that we studied is hypertension. Now okay, now let us move back again right here. Now what will happen here is there will be antigen, right? There will be antigen that will come, right? That will come and cause what? Inflammation in our glomeruli, and at that time what will be happen? There will be formation of antibody, and these antibody and antigen, they will form immune complex. As there will be immune complex formation, there will be activation of complement system, and as there will be activation of complement system, what will happen? There will be inflammation. right? There will be what? There will be inflammation in glomeruli, and that is what we call what? Glomerulonephritis. What we call that thing? That we called glomerulonephritis. Yes, as I have already mentioned, as there will be inflammation in glomeruli, there will be what? Decrease in what? Glomerular filtration rate. As there will be decrease in glomerular filtration rate, there will be activation of RAS system that will cause what? Hypertension. And decrease in glomerular filtration rate will cause decrease in urine output, that will cause what? Oliguria, and that's less than 400 ml per day, right? And another cardinal feature is our proteinuria. We have already mentioned mainly what? Mainly our albumin. And similarly, the urine is what? Present in urine. Normally it is not present, but in the case of glomerulonephritis, there will be presence of RBC in our urine. So what? That condition is called our hematuria. So what are these? These are hematuria, proteinuria, this hypertension, oliguria. These are what? These are the cardinal sign of nephritis, right? Now, yes. Okay, now talking about hematuria, the thing that we need to mention right here is, right, there will be presence of RBC in urine or blood in urine, and those RBCs are not what? Of normal shape and size. They are of what? They are of abnormal morphology. As you can see right here, what is this? This is abnormal, right? Abnormal. And what is this? Morphic. That's morphology. That means abnormal morphology RBC are present. Now why this happen? Because when RBC pass through inflamed glomerulus, they change the shape. That's why it is happening like this. So now, as we're talking about hematuria, now what will happen is, in high power field, there will be more than 3 RBCs in 3 samples within 1 week apart, and this will just emphasize on our hematuria, right? In order to be called hematuria, because of glomerulonephritis, we'll find what? We'll find a great more than 3 number of RBCs in high power field in 3 samples, and that will be taken 1 week apart. Similarly, we talked about dysmorphic Rbc. That means dys means abnormal shaped, abnormal morphology RBC, and this occur because of what? Because of glomerular hematuria, or while passing through glomerular inflamed glomeruli. But there is another condition, that is what? Isomorphic Rbc also. This isomorphic means what? Of similar shape, and this isomorphic Rbc, they are found in non-glomerular hematuria. Where they are found? They are found in non-glomerular hematuria, and this occurs in what? This occurs in the case of what? In the case of our stones. This occurs in the case of stones. It occurs in the case of tumors, right? And yes, we talked about what? Dysmorphic RBCs. They are found where? They are found obviously in what? Nephrotic syndrome. Okay, now another thing that we need to just add right here is, now this hematuria, because of hematuria, what will happen? Our urine, it will be of what color? It will be of cola colored. What? Cola colored, dark brown color. And as we have already mentioned in previous lecture, that our physiological cyst, that is what? That is Horsfall cyst, right? The Horsfall field at that Horsfall cyst. Now what will happen is that physiological cyst will what? It will attract RBCs. It will attract a lot of RBCs, right? A lot of RBCs. Now since there are what? A lot of RBCs because of passing through glomerulus, right? Now these physiological cysts, which was called Horsfall cyst, now it will be what? It will be the pathological one, right? And there will be what? RBC cyst will be seen. Now okay, now talking about RBC cyst, the thing that we need to mention is that these RBC cysts are not found just only in nephritic syndrome. These are found in other condition also. Okay, we have already mentioned one, what? Nephritic syndrome or glomerulonephritis, right? It is same thing, glomerulonephritis. Now similarly, another condition is our what? It will be found in malignant hypertension condition also. It will be found in the case of vasculitis. Similarly, it will be found in the case of what? In the case of our, just excuse me, it will be found in the case of thrombotic what? Microangiopathy. Thrombotic microangiopathy. Thrombotic microangiopathy. Okay. Yes, we are talking about RBC cysts. They are not found just in glomerulonephritis. They are also found in other three conditions. They are malignant hypertension, vasculitis, and thrombotic what? Microangiopathy. So this is important to know. Now the moving further. Now the thing that we need to discuss here is, okay, now let us move to what? Post-Streptococcus Glomerulonephritis. Okay, this Post-Streptococcus what? Glomerulonephritis. What is this? This is what? This is, we are studying this under acute proliferative, right? Now what is acute proliferative? That means acute means what? For short duration of time. For the short duration of time, and proliferative means they are just what? Growing. Proliferative means just growing. Okay, that means now we are talking about what? Post-Streptococcus Glomerulonephritis. Now as name suggests, post, that means after. After what? After streptococcal infection, right? After streptococcal infection, there will be what? There will be glomerulonephritis, right? This is called PSGN. Now what will happen here is, okay, it is mainly, okay, now let me just again recall the thing that we have just gone through, and the things are what we are talking right now. We are talking about what we're talking about acute proliferative what? Glomerulonephritis, right? On this acute proliferative glomerulonephritis, we are what? We are talking about what? Post streptococcal glomerulonephritis, right? Now yes, I have said why it is acute. It is acute because it takes place what? For short duration of time. For short duration of time. Now proliferative because the cells of glomerulus are what? They are rapidly dividing. That's why. Now it will occur, this acute proliferative glomerulonephritis will occur due to what? Due to immunocomplex, due to formation of immunocomplex, right? Okay, as we have already mentioned right here, it will occur because of what? The formation of immunocomplex. Now this immunocomplex, what are the source of immunocomplex? The source are what? One is our exome, right? Exotic source, and another is our endemic source, right? Now talking about what? Exotic source, what is that? That is what we are talking right now, and that is what? That is our streptococcus what? Infection, streptococcus pyogenic infection. Talking about endogenous source, right? Endogenous source, it is our SLE, right? SLE. So now here, okay, we just got some idea, right? So here we are talking about what? We are talking about our what? Post streptococcal glomerulonephritis, right? PSGN. Now it is mainly found in what? In children. It is mainly found in the case of children, right? In pediatric age. So from P we have got what? We can just remember it as acronym. So but it is not just found in the case of children, it is also found in the case of what? Adult also, but it is mainly found in the case of in the case of children. Okay, now it is when there will be patient, right, and that will be of what? That will be of pediatric age, and that patient will what? That patient will just present with a history of what? Infection in skin or sore throat, right? And what and this present history of skin and what? Our sore throat, that will be because of what? Because of infection by what? Group A beta hemolytic streptococcus, right? And it is also called what? Streptococcus pyogenes, right? Streptococcus pyogenes. Now the stain that is responsible right here is 4, 12 and 1, right? These are the important stains that have higher chance of causing involvement of kidney, right? This will cause the involvement of kidney mainly. Okay, now what will happen here is, right, now as there will be what? As there will be our as there will be what? As there will be our child, right? As there will be our child, this child will suffer from what? This child will suffer from infection of streptococcus pyogenes or group A beta hemolytic streptococcus, right? And they will suffer from sore throat or infection in skin, right? Okay, Now these, the sore throat and infection in skin, that is what, that is because of what, because of our different toxins present in our what, our streptococcus, that is what, streptococcus exotoxin B, right, streptococcus, our streptococcus pyogenes exotoxin B, we have what, M proteins also, right. Now these what, these our exotoxins, what they will form, they will form immune complex. As they will form immune complex, right, and there will be what, glomerulonephritis, right, glomerulonephritis. Now here the thing that we need to know is, here it is caused because of what, it is caused by streptococcus pyogenes of what, of subtype our 12 of stain 12, 4 and 1, right. And during this time, during this initial infection, and these glomerulonephritis will take place after about 10 to 14 days, after about 10 to 14 days of infection, after about 10 to 14 days of infection. Now here at this time there will be what, there will be transient hypocomplement, right, there will be transient decrease in complement, right, complement serum, our serum C3 level will be slightly decreased, and that is our called what, hypocomplementemia, that is called hypocomplementemia. So here what is going on, the thing that we need to know is, we need to know about what, we need to, here the thing that we need to just remember is, it occurs in mainly in pediatric age group, and it after infection, right, about after what, 10 to 14 days there will be our glomerulonephritis, and here what will happen, there will be transient, right, transient hypocomplementemia, right, and the streptococcal pyogenes, that the strain of streptococcal pyogenes that will be involved is our 12, 4 and 1. So here now, okay, now here because of inflammation in glomeruli, what will happen is, there will be diffuse diffuse what, there will be our WBC infiltration also. Now here another thing that I would like to mention is, here there will be diffuse glomerular involvement. Now this diffuse glomerular involvement, what does this means is, right, now this means that whole, what, this means the whole entire glomeruli of kidney are involved, right. And I would like to take you here right now, because here it is mentioning about these things, right. So now many primary glomerulopathy are classified on the histology, but the histological change can be further subdivided by distribution in following category. One is diffuse. Here there will be involvement of glomeruli in kidney, right, involvement of all glomeruli in kidney, right. And global, what is the global? The global means involving entirety of individual glomeruli, that means one glomeruli will be completely involved. Now another, there is what, there is focal. The focal is fraction of glomeruli will be only involved. Similarly the segmental is there, that means some of the part of glomeruli are involved. So what is telling right now is, this is our kidney, right, the every glomeruli, right, every glomeruli, if there will be involvement of every glomeruli, that will be what, that will be our diffuse, right. If there will be involvement of what, only one glomeruli, that will be called what, that will be called our global, right. And if there will be involvement of only fraction of glomeruli, then that is our what, focal, right. And there will be involvement of just some segment of our what, glomeruli, such as capillary loop, mesangial, then that is our what, that is our segmental. So I think it's clear now. Now here, yes, we are talking about what, there will be diffuse glomerular involvement with WBC infiltration. Now this is type 2, this is type 3 hypersensitivity reaction. Why it is type 3? Because here is what, antibody antigen what formation, or here there is what what is going on here, there is the formation of our what is going on here, there is the formation of our immunocomplex formation, and we know the immunocomplex formation, it is shown in what, it is shown in type 3 hypersensitivity reaction. So if you recall the other example of type 3 hypersensitivity reaction, then we just memorized it how, as SHARP, right. And this, from this P, what we studied about Post-Streptococcus glomerulonephritis, right. And from this S, what was this S? This S was what? This S was our SLE, serum sickness. Our this H was what? This H was our Hennon's Slenion purpura, right? And from this A, this was ortho reaction, anthrax reaction. This R, what was this R? This R was what? Reactive arthritis, right? And these were what? These were type 3 reactions. Okay. Now yes, we already mentioned about this thing. Time taken from what? In history of skin infection or sore throat to clinical what? Clinical manifestation of glomerulonephritis is 10 to 14 days. Right, now talking about the clinical feature, yes, hypertension, we already mentioned about these things, hematuria, and that is cola colored urine, oliguria less than 400, and proteinuria, albumin is seen in urine. Now how we will diagnose? Now in order to diagnose it, what we will do is, we will do urine examination, we will do blood examination, we will do what? A renal biopsy, right? Now initially moving toward urine examination, yes, altered color of urine. Why? Because that will be cola colored because of RBC, blood in urine. Decreased urine output, yes, that we have found, less than 400 ml per day. RBC cast are seen, yes, in our what? TAM horseful cast, there will be RBC attaching, right? Here you can see there is our TAM horseful, there were RBC is right here attaching to it, so it is called what? RBC cast. Now what? Now talking about blood, the diagnosis in blood, what we will find is, we will find decrease in C3, serum C3 protein, right? Serum C3 protein in active stage, and this is what? This is what? Yes, we discussed about this thing, that is our transient hypocomplementemia, right? Okay. Now what we will find? We will find what? Antibodies, and the antibodies that we will find is, we will find anti-streptolysin O antibody, and also what? Anti-DNA DNase B body antibody, right? Anti-DNase B antibody. This anti-streptolysin O antibody, it is mainly what? It is mainly related with our what? It is mainly related with our rheumatic fever. If you remember rheumatic fever, this is mainly found in the case of our rheumatic fever. Now but this, what is this? This is our anti-DNase B antibody. It is what? It is more significant for diagnosis, for diagnosing our what? Glomerulonephritis. Now moving toward renal biopsy, and in this renal biopsy, the thing that we need to know is, yes, what we are doing, we are just picking up renal tissue and we are examining this renal tissue, right? How we are examining this renal tissue? We are examining under three topic. One is light microscope, another is what? Electron microscope, another is our immunofluorescence, right? Now in light microscope, what we will see is, there will be what? Diffuse involvement, that means entire glomeruli of kidney will be involved, right? And yes, and another what we will see is, we will see there is what? There is our growth, I mean proliferation of cells of glomeruli. So what we will see? We will see a diffuse type. We will see here there is diffuse involvement, right? And we are looking electron microscope. In electron microscope, the thing that we will see is, we will see the presence of what? Presence of immunocomplex, and we will find this presence of this immunocomplex mainly in what? In what? We will find this mainly in the region above podocytes, and that is what? That is subepithelial immune complex. If you remember, that is what? Subepithelial immune complex. Okay, yes, we talked this in basic portion, that what? There will be deposition of immune complex in different region. If it will be present what? If it will be present just what? Just in the region of endothelium, then it was what? It was endothelial, right? And similarly, if there was presence in the region of basement membrane, then we are calling it as what? Submembranous. Similarly, if they were present just above our podocytes, they were called subepithelial immune complex type. Okay, yes, we talked these things at that time in lecture of basic. Okay, now out of these, what we said, that there is what? There is presence of immunocomplex mainly in the region, mainly of which type? of subepithelial immune complex site, that means just above the podocytes. There are presence in this region also, that means in the region of endothelium, in the region of what, in the region of our submembranous space also, but relatively what we will find maximum in the case of what, subendothelial, right, epithelial, not endothelial, subepithelial region. Why? Because as I have already mentioned, the subepithelial space are the space just above our podocytes, and we know the podocytes are negatively charged, and here in this case what is going on is there are the cationic immunocomplex. The immunocomplex are cationic. So what will happen is this cationic immunocomplex will just go and will bind in the region of our these podocytes. So what we will find most prominently the presence of our immunocomplex in the region of the epithelium, right, visceral epithelium, that is what, subepithelial immune complex. Now in fluorescence, immunofluorescence, the thing that we'll find is we'll find granular appearance. Now this granular appearance, right, it is why there is the granular appearance, because of deposition of IgG antibody and also C3 proteins, right, IgG antibody and C3 protein. Okay, now why there is, okay, one important thing that I'd like to mention right here in the case of our streptococcal pathogens there is IgG formation, but in the case of Streptococcus aureus there is the formation of IgA, and that is one microbiology link. Now here there is our granular granular appearance because of IgG and C3 involvement. And another thing that I would like to mention here is, right, here the granular appearance is given name of lumpy bumpy appearance. What? Lumpy bumpy appearance. It is also called what? Starry sky appearance. Okay, as you can see right here, this is our starry sky appearance, right? Okay, yes, here you can see this is our steady sky appearance. What will happen here is you will see star like things on dark background, so it is steady sky appearance. And here you can see subepithelial humps, the thing that we're talking in electron microscope. What? Subepithelial humps. As you can see, what are these subepithelial humps? Right here, right, these are subepithelial humps. Okay, now okay, yes, we said that we are going to look light microscope, electron microscope and immunofluorescence, right? Now here, yes, we talked about what? We talked about yes, there will be immunocomplex presence in the region of subendothelial, intramembranous and subepithelial, right? The subepithelial are called what? Subepithelial humps, and these are most common, yes, as I mentioned right here, right? Yes, right here. Now there is steady sky appearance, and okay, now what I would like to do is, as you can see, this is the diagram of our Robbins. This is A is our normal glomeruli, right? You can see right here that this is our normal glomeruli, but this is our what? This is our nephritic glomeruli. How we can know that? We can see what we can see is, we can see there is what? A lot of proliferation. You can see a large number of cells right here, right? A lot of compactness. And here this is what? This is our subendothelial hump, right? Subendothelial hump that we'll see in electron microscope. And what is this? This is starry sky appearance, right? Immunofluorescence finding, you will find what? Star-like appearance, as you can see, with the green color in dark background. So this is all about it. Now how we are going to treat it, right? How we are going to treat the portion? We are going to treat the portion how? We'll provide what? Antibiotics against what? Streptococcus pathogens, right? And these antibiotics are so efficient that there is complete recovery. In maximum cases there will be complete recovery, but there is not complete if there will not be complete recovery, and there will be what? Worsening of situation, then there will be a condition that will rise to what? Rapid proliferating glomerulonephritis, and that we'll discuss in next lecture. So here, okay, I would like to again revise the same thing. It is type 2 hypersensitivity reaction. There will be, it is immune complex mediated one, and it occurs mainly in 5 to 15 years of age, that is pediatric age group, and after it occurs after what 2 to 4 weeks, that means 10 to 14 days we mentioned, right? Okay, it is okay. After 10 to 14 days of sore throat, what will happen? There will be the clinical manifestation of our glomerulonephritis, and it is mainly caused by what strains 12, 4 and 1, right? And clinically we'll find cola colored urine, we'll find edema, especially on the region ocular edema, we'll find hematuria. Microscopically, what we'll find in light microscope, we'll find enlarged hypercellular glomeruli, increased cellularity by leukocytes, endo and extracapillary proliferation. In electron microscope, what we're finding humps, right, due to immune complex deposition. And in immunofluorescence, we are finding what? We are finding lumpy, bumpy deposit and also starry sky appearance. So without delay, let's go toward the content of what? Let's go toward the content of our first aid. We talked about nephritic syndrome, right? Nephritic syndrome. Now what is this nephritic syndrome? This is our glomerular inflammation. What will happen? There will be what? There will be glomerular basement membrane damage that will cause what? That will cause the filtration or loss of what? RBC into urine. And here it is not isomorphic, it is dysmorphic, abnormal one, and abnormal RBCs, and it is what? It is our hematuria. Clinical presentation, hematuria, yes we know. RBC cast, yes we have already discussed. And we have what? Decreased glomerular filtration ratio, that is what? Oliguria less than 400. Azotemia, what? Increase in serum complement, increase in serum what? Our creatinine, right? Now there will be increase in renin release, hypertension will occur because of that, right? There is proteinuria, right? Proteinuria, mainly what? Our albumin. Now the example of nephritic syndrome, yes, the one that we talked in detail is our acute post-streptococcal glomerulonephritis. Other thing that is remaining to discuss is our Goldwasser syndrome, IgA nephropathy, that is Berger's disease, Alport syndrome, membranoproliferative glomerulonephritis. Okay, now talking about nephritic syndrome, specific nephritic syndrome that we discussed in this chapter, and that is in this topic, that is acute post-streptococcal glomerulonephritis. Yes, the same thing, nephritic syndrome, we'll just memorize it in this way as inflammatory process. Most frequently it is seen in children 2 to 4 weeks after group A streptococcal infection of pharynx or skin, also called post-infectious glomerulonephritis when caused by non-streptococcal pathogen. Okay, right? Okay, now it resolves spontaneously in most children, may progress to renal insufficiency in adult. It is what? It is type 2 hypersensitivity reaction. It is presented with what? Peripheral or periorbital edema, right? T or cola colored urine is seen, hypertension is seen. What will happen? There will be positivity for streptococcus titer serologically. There will be decrease in complement level, that was what? Transient hypocompletemia due to consumption, right? They are consumed. Now in light microscope we are finding what? Glomeruli was enlarged and hypercellular. In immunofluorescence we are finding what? Starry sky, granular appearance, lumpy bumpy, due to what? Due to IgG, IgM and C3 deposition along with what? Our glomerular basement membrane and mesenchyme. Now okay, I think something is remaining, and that is our what? Electron microscopic finding. What was electron microscopic finding? There was subepithelial hump, presence of subepithelial hump. Okay, now let's see. Yes, we discuss about these things. Now let us move right here. Yes, this is the same thing. This is what? This is our glomerulus, which is enlarged because of hypercellular, because of what? Proliferative, right? And what is this? These are steady sky appearance, right? And these two, these are found in acute what? Post-Streptococcus glomerulonephritis. Yes, we discussed about these things, and what? This much for our what? Nephritic syndrome. Now in next, this much for acute proliferative nephritic syndrome and our what? Our post-streptococcal nephritic syndrome. Now after this, the thing that we are going to talk about is we are going to talk about rapid proliferative glomerulonephritis, or our, and under that we'll be talking about Berger's disease. So this much for this lecture. Thank you and have a good time.